Summative final examination. National ratification of an assessment framework of these skills is not currently available in the United Kingdom. Indeed, formal final assessments similar to models such as ALS, which certify competence by successful completion, would not be realistic for such highly used skills. Instead, final assessments tools that are locally endorsed could offer a more robust and accessible way forward. All assessments should be designed to demonstrate knowledge, skill and competency achievement and be sufficiently clear in order to avoid the need for retraining when changing roles. Comprehensive assessment guidelines are equally important in order to achieve a valid, reliable and fair assessment. Reasons to adopt acknowledges that learning has been achieved to specific standards. This gives clarity and a goal for the learner while assuring the organisation that a set level of competence has been achieved. It also provides clear evidence to professional bodies in the event of adverse clinical incidents. The Objective Structured Clinical Examination is an effective assessment tool commonly used by medical schools in their clinical competence exams and is usually performed in a simulated environment or a skills laboratory. It is a clear and concise tool. The OCSE, in its original simulated environment, is argued as inadequate as a sole method of assessment for nursing students because it does not accurately replicate a ward environment. However, adaptations to the OSCE to make it applicable in the clinical environment yet still objective have been made by the VAN and were reported as successful by Collins et al. Professionals Learning, Adult Learner. Lorge, writing about effective methods in adult education, suggested that to reach the adult learner you have to teach what adults want. He stated that adults have wants in the following 4 areas. 1. To gain something. 2. To be something. 3. To do something. 4. To save something. 2. Venipuncture and cannulation. Multi-professional learning. In the late 1990s, in many hospitals, junior doctors had responsibility for cannulation, although Doherty reported that specialist nurses in the fields of cancer, cardiac and intensive care also fulfilled this role. Currently, it is carried out by a range of suitably prepared healthcare professionals, including, but not exclusively, nurses, paramedics, radiographers and healthcare support workers. The government and professionals endorse training and competence over a role-specific approach. Intravenous cannula insertion will be carried out by trained and competent staff using strictly aseptic techniques. It is suggested that cannulations are less traumatic when carried out by someone who has regular practice. Lavery also highlighted that frequent practice in enhanced clinical skills is essential. The decision as to who should practice venipuncture and/or cannulation should therefore be based on whoever is best placed to learn, maintain and update their skills. It should not be determined by professional status, prior experience or enthusiasm. Each professional group will bring to these skills relevant experience according to their background and primary task. The primary task of a doctor, for instance, could be identified as diagnosing, compared to a nurse's primary task of caring. This understanding is useful when trying to understand puzzling responses or feelings of anxiety that can block competency achievement.